Hello, I'm Josh Klopper. I'm the Medical Director of Endocrinology at Veracyte, and I'm pleased to present our poster, Thyroid Nodule Risk Stratification, mRNA Expression-Based Tumor Behavior Prediction Models. By way of disclosure, please note that I'm an employee and equity owner of Veracyte, as are all the co-authors on this study. So we know that the risk of structural disease recurrence, the stratification system here proposed in the 2015 American Thyroid Association Thyroid Nodule and Thyroid Cancer Guidelines, is largely dependent on the extent of invasion and lymph node metastases, as seen here with the spectrum from low to high risk disease. Molecular testing provides information on gene variants and fusions, and those are very helpful for predicting such factors as invasion and metastases over a population, but they are not particularly specific for how an individual tumor may behave. The objective of this study is to provide a risk signature for thyroid cancer, invasion, and lymph node metastases to better predict tumor behavior. Over 300 pathology reports from Afirma genomic sequencing classifier algorithm training were reviewed. There was an integer assigned to indicate the extent of invasion or metastases, as seen here. And over 400 literature-derived expression-based signatures were tested against invasion and metastases labels to find potential predictive signatures. Candidates were derived from the literature or from a Veracyte internal expression signature database. Then those signatures were applied to samples that were Bethesda 3 and 4 or indeterminate thyroid cytology and GSC suspicious or Bethesda 5 and 6 cytology. Thresholds for very low risk or high risk of invasion and metastases were assigned for each signature. As you can see, approximately 2/3 of the path reports were derived from indeterminate thyroid nodules. And the levels of invasion and metastases that were at those higher ends were very low in those samples. For metastases, there was a limitation that most samples did not have dedicated lymph node dissections, and over 50% were designated NX. For Bethesda 5 and 6, as expected, there was a higher proportion of invasion and metastases for any level of invasion or the highest levels of invasion and metastases. Figure 1 shows thresholds that were assigned to indicate low levels of invasion or low metastatic potential. And the negative predictive value for no invasion or metastases was 95% and 100% respectively. Those samples that were above the threshold line have a higher likelihood, or at least a similar likelihood as the baseline, to have invasion or metastases. Alternatively, in figure 2, this is the threshold that was assigned for which invasion and metastases are enriched amongst these samples. And given the low prevalence of high levels of invasion and metastases, we only found a positive predictive value of 57% for invasion and 41% for metastases. So samples that are below the threshold line have a similar or lower likelihood of that aggressive behavior as the baseline prevalence, which again was very low in our cohort. So to summarize, rates of clinically significant invasion metastases are less than 5% in the studied cohort of malignant thyroid nodules with indeterminate thyroid cytology. And these preliminary invasion metastases signatures best identify a subset of samples that have a low risk of invasion metastases. So this may allow for a confident de-escalation of surgery when faced with indeterminate thyroid nodules that are Afirma GSC suspicious. When deciding about a total thyroidectomy or a lobectomy, these signature may aid in pulling back on the aggressiveness of surgery. Thyroid cancer risk of recurrence does depend on these factors, such as invasion and metastases, but of course, the patient's response to therapy will be the ultimate indicator of whether there's going to be structural recurrent disease. And so expression-based signatures of tumor invasion and metastases may help personalize the preoperative interrogation of the neck, modify the surgical approach for those patients with thyroid nodules, and optimize the initial response to therapy to decrease the risk of recurrent thyroid cancer. Thanks so much for your attention. I hope to see you in person at the American Thyroid Association meeting in Montreal. If you are there, please swing by our poster, which is presented on Thursday, October 20th. We'll be in the late-breaking abstract section. Take care.